على السبوندايلوليثيسيس.
الصورة سبوندايلوليثيسيس ابتدت تظهر كده.
ايوه ظهرت يا فندم، ظهرت.
أيوة.
ظهرت. اتفضل يا أشرف.
انا اللي عندي حاجه كده الايه I don't know what is this. Just wait please. نتكلم على السبوندايلوليثيسيس. سبوندايلوليثيسيس من التوبكس اللي هي اتغير التفكير فيها ما بين الاولد schools and old teaching and the recent since the 2000s. The outline of the talk: introduction, definition, epidemiology, sagittal balance and the pelvic balance, pathophysiology, classification, clinical assessment, natural history, progression, treatment, rationale, and cases. Spondylolisthesis is the slipping of the cephalic vertebra over the caudal vertebra or the superior vertebra over the inferior vertebra, and first described or noticed by Benha, which was a Belgian obstetrician, and he found that a case with him with a very difficult labor and a very narrow labor canal. بعض الكلام على السبوندايلوليثيسيس. treatment of spondylolisthesis still a challenge, and the spinopelvic morphology and the sagittal balance changed the mind of the surgeons for this. The proper treatment of spondylolisthesis is dependent on recognizing the type of slip, the sacropelvic balance, and the sagittal balance and its natural history. The epidemiology or the incidence of spondylolisthesis in this general population is about 6%, with male to female ratio of 2:1. يعني احنا لو قلنا كده ان مصر هيبقى فيها about 6 million people having spondylolisthesis. يعني تقريبا دول population قد يعني هم جمهورية لوحدها يعني. The incidence of spondylolisthesis in children under 6 years is 2%. The degenerative spondylolisthesis is rarely affects individuals below the 40 years. And is 4 to 5 times more common in women than in men. In a study by Love in 2000s, subjects who had facet orientation more than 45% in the sagittal plane, they were 25 times more likely to develop degenerative spondylolisthesis. And there is also a genetic and familial association for spondylolisthesis. 26% of patients with isthmic spondylolisthesis has first degree relatives with the same disease. الحقيقة دخول الساجيتال بالانس في الموضوع، والساجيتال بالانس ده كان ابتدى يتكلم عنه واحد فرنساوي اللي هو رسولي سنة 2003, and he presented his paper for the sagittal balance and types of sagittal balance. Sagittal balance, sacropelvic morphology now is the key of treatment. What is the sagittal balance? Static sagittal balance of the normal spine is a physiological alignment of the spine in the efficient manner by the muscular forces. يعني إيه؟ يعني ده normal physiologic pattern of the subject that where there is the least amount of forces on the spine shared or caused by the muscles of the muscles anterior and the posterior and the paravertebral muscles. Numerous ways of assessment this, the bony landmarks and angles to evaluate the sagittal balance. أشهرهم اللي هو the plumb line. Individuals with abnormal sagittal balance are apt to progressive spinal deformity and pain. The sagittal balance plumb line, which extends from the center of C7 and it passes normally through the posterior 2 centimeters of the upper end plate of the sacrum. It should pass through it. If it is in front of the spine or in front of the S1, it will be positive sagittal balance. If it is behind it, it is negative sagittal balance. As we see here, this is a case of scoliosis, but actually it is balanced both coronally and both in the sagittal plane. Classification or the Rosuli classification of the types of the sagittal balance, type 1, 2, 3, 4, type 1, which where there is long thoracolumbar kyphosis, long thoracolumbar kyphosis, and a short hyperlordosis. Type 2, where is the flat lordosis. This flat lordosis, as we see here down, there is maximum loads and stresses on discs with a high risk of early disc herniation and also a high incidence of what is called the nutcracker mechanism, leading to isthmic or fracture of the pars interarticularis. Type 3 is nearly the normal sagittal balance, and with no characteristics for the loads, no characteristic difference of the loads, and in such cases, usually the sacral slope is about 45 degrees or around it. In type 4, where is long curved lumbar spine, and this is the spine for the isthmic spondylolisthesis, where the pars interarticularis fails in tension or repeated tensile stresses over the pars interarticularis, and this is in the high angles sacral slopes. Rosoli then subclassified it for the degenerative spinal, degenerative spondylolisthesis or degenerative spine with age into subgroups in the type 1 and type 2, type 3, and type 4. Now, the spinopelvic parameters, which are the second part of the assessment of the spondylolisthesis. We have the pelvic incidence, the pelvic tilt, and the sacral slope. The pelvic incidence, we have only 2 points in the lateral view erect lumbosacral view, lateral view, erect, standing, lumbosacral view. We have the midpoint of the upper of the sacral plateau, we have the central point of the head of the femur. These are the most important points, and we'll have lines connecting in between and angles in between. The pelvic tilt is the angle between the line of the center of the head femur and the midpoint of the sacral plateau. This line and the angle between this line and the vertical line is called the pelvic tilt. The sacral plateau, the line of the sacral plateau, which is the angle between the line of the sacral plateau and the horizontal reference line, is the sacral slope. The sum of the sacral slope and the pelvic tilt equals the pelvic incidence. Now, the angle of the pelvic incidence is the two lines. We have the perpendicular line on the midpoint of the sacrum and a line from the midpoint of the sacrum to the center of the head of the femur. This is the pelvic incidence. As we see, the relation between the sacrum and the pelvis, this is fixed. It is a fixed. It is fixed. So, but with the relation to the center of the femur, it is positionally different. But it is in harmony with the sagittal, with the sagittal balance, with the lumbar lordosis, the rest of the lumbar lordosis, the dorsal kyphosis. But in cases of spondylolisthesis, this harmony is disrupted by the breakage or the fracture of the pars interarticularis. Here we have the two mechanisms of the pars break, the nutcracker mechanism and the shear mechanism. The shear mechanism is with the high sacral slope and pelvic incidence, where there is repeated tensile stresses over the pars interarticularis, leading to its failure and slippage. The other mechanism is the nutcracker mechanism, where is the pars interarticularis fails under the weight of the body and the fulcrum caused by the sacral plateau. Meyerding, 1932, classified the slippage of spondylolisthesis into 5 grades according to the degree of slippage of the vertebra above L5 over the S1 into 25%, 50%, 75%, 100%, and then dropping of the L5 over in front of S1 in what's called the spondylolisthesis or spondyloectasia. Here are the pelvic incidence, as we said. في الحالات اللي هي يعني الصور بيبقى فيه 2 femoral heads، بناخد point في واحدة والثانية، ويبقى نوصل ال 2 central points, and the midpoint will be that reference point. Here is another type of measuring the sagittal balance, the midpoint of C7 and the posterior part of S1 with a referral vertical line. The distance is between this referral line with C7, the referral, and the distance between the S1 and this line, we measure this. Classification, different classification. One of the oldest classifications is according to the cause or the etiology into congenital, spondylolytic, traumatic, degenerative, pathological. Myerding grading, the one that we are talking about it, Myerding actually classified according to the sleeping, and it is still one of the columns of classification and grading of spondylolisthesis. The spine deformity study group classified in the 2000, after 2000, I think 2015, into low grade and high grade. Low grade means more than 50% slippage, high grade, less than 50% slippage, high grade, more than 50% slippage. And then they classified it into type 1, type 2, type 3, according to the pelvic incidence. If it is 150 or 45 degrees, and if it is more than from 45 to 60 degrees, which is usually, this is the normal, the normal grade. Type 3, the pelvic incidence more than 60 degrees. With high grades, we have the balanced pelvis, but high grade and more than 50% slippage, and retroverted pelvis and the vertical sacrum. Here is the type 1, as we said. As we said, type 1, type 2, type 3, these are the low, the mild or the mild slippage. With the high slippage, the other 4, 5, and 6, which there is pelvic incidence more than 60 degrees. And as we see here, there is at type 3, more than 60 degrees, the pelvic incidence, and it reached 95 with vertical sacral slope. Then, with continuation of the slippage and trying the lumbar spine, trying to accommodate again the pelvic incidence, and the sacral slope starts to decrease with sliding of L5 over over the S1 until we reach the most unstable and the spondylolisthesis with concave the concave back all over the lumbar spine and the dorsal spine. The EO classification on 2017, they have the columns or the parameters of the EO classification was the grief, the slipping, pelvic incidence, pelvic balance, spine balance, and the lumbosacral kyphosis. Type 1, where there is characterized by spondylolysis or listhesis less than 50 degrees. With pelvic morphology, low pelvic incidence less than 45, both pelvis and spine are in balance, and there is no lumbosacral kyphosis. With type 2, which is characterized by listhesis less than 50% with pelvic morphology, normal pelvic incidence, both the spine and the pelvis are in balance and no lumbosacral kyphosis. Type 3, which is the characterized by less than 50 degrees listhesis, but the high pelvic incidence, but still the pelvis and the spine are in balance and no kyphosis. Type 4, more than 50% slippage with the pelvic morphology, high pelvic incidence, and both pelvis and spine are in balance, no lumbosacral kyphosis. Type 5, the L5 will start to dislocate, and the sacrum will start to be verticalized. High pelvic incidence retropelvic pelvis, but still the spine is balanced, and kyphosis here requires reduction. Type 6, where is the loss of the balance of the spine. The pathophysiology here, we have the catch mechanism, the hook and the catch mechanism. The hook and the catch mechanism is that mechanism that holds the upper vertebra to the lower vertebra all over the vertebral column. Where is the, as we see here, the inferior process of the cephalad or the upper vertebra with the pars interarticularis and pedicle. Here is the hook, and the catch is the lower vertebra. This is the mechanism all over the spine. Failure or weakness of this mechanism will lead to the spondylolisthesis. And we have two types of the pathophysiology, is dysplastic pattern and traumatic pattern. With the dysplastic pattern, ده عامل زي البلاون disease of the tibia, where there is weakness in the hook and catch mechanism, and under the body weight with growing the body weight transmitted through the weak zone, soft tissue restraints, and the plastic deformation of the upper sacral plateau. The growth plate will be overloaded. With the other traumatic, the traumatic pattern, there is repetitive cyclic loads and stress fracture of the normal pars, and which predisposes to vertical slippage. Here is the dysplastic pathology, where is the proximal sacral rounding, trapezoid L5. Here is also what is the similarity between the dysplastic type and the blount disease, where the spondylolysis leads to mechanical failure and the stresses over the growth plate of the upper sacral of the sacral plateau with physial vertebral stress fractures and the growth plate slippage. Now, for the clinical evaluation, this is a case of back pain. The back pain, the chronic muscle spasm, it's the painful pars, the annular tears with root compression and root traction by slipping. The leg pain from L5 compression, abnormal motion, facet joint arthrosis, pars scar, which may add to the traction over the root, and the disc degeneration of the disc above. We will have back pain, leg pain, neurological symptoms, all differs in the severity. With examination, we should check the range of trunk motion, neurology, which is of importance, and here the sagittal alignment and gait. In such case, as we see here, this is a grade dysplastic type with rounding of the sacrum, with trapezoid L5, which is slipped in front of the sacrum. We had, as we see, we have flexion of the hip, flexion of the knee, and this unbalanced spine. Imaging is that very important. We should have an erect, standing, AP and lateral, including the hips. We should notice, ناخد بالنا من ان lumbosacral view, lateral lumbosacral view, and not lumbar view, because the lumbar view, the central beam will be superior, maybe at 2, 3 disc or the vertebra 2. But with lumbosacral view, we concentrate on the L5 and S1, and it should contain the heads of the femur. Whole spine also is important to standing whole spine is important to assess the sagittal balance. We have to measure the pelvic and the pelvic parameters. We have to assess the disc degeneration and facet joint degeneration and orientation. Disc degeneration in MRI, we have the 5 grades of disc degeneration, where grade 1 is the normal one. Grade 2, there will be a slit, opaque slit, but still the nucleus is still with the same intensity as the CSF. Darkness will start in grade 3 and will increase in grade 4 till it will, the disc space will disappear completely in grade 5. The facet joint, the orientation of the facet joint will be obvious in the CT and the MRI also. Facet tropism is the difference between the right and left angles of the facets. It's mild if it is less than 5 degrees, moderate from 7 to 15, and severe to more than 15, which will lead to facet degeneration and spondylolisthesis. On MRI, we will have the degrees of facet degeneration according to the thickness of the cartilage and the thickness of the subchondral sclerosis and the osteophytes. Also, we should assess the severity of spinal stenosis in the degrees, severe degrees of the spondylolisthesis. Spondylolisthesis, will it slip more or not? 50% of persons with a pars lesion during growth spurt will slip more, minimal changes after 16 years. Usually there is no pain with progression of the slippage. Most of the cases are asymptomatic, and 90% of slips at initial presentation do not progress. Adolescents more than grade 3 are likely to progress. Grade 1 and 2 after mid-adolescence are unlikely to progress. The L4-5, L3-4 are less risky to progress. The risk of progression in the young adults with disc degeneration is less marked to progress, as we see here. With time and with age, there is no increase in the degree of slippage. With the increase in the degenerative changes of the disc. Treatment rationale. الحقيقة إن we don't have till now for, or طبعا في ناس بيحاولوا إنهم يعملوا algorithms, but no distinct criteria For this type, we will treat it like that. This type will treat it in another one. This type will treat it in another one. But there are criteria for surgery in spondylolisthesis, group into groups: type 1, type 2, type 3, type 1, type grade A and B. In type 1, children and adolescents with low-grade spondylolisthesis, the indications of surgery will failure to respond. What happened? Failure to respond to conservative treatment, and indications includes the progressive slippage, pain, and neurological deterioration. Children and adolescents with high-grade sleep, so type the A, low-grade sleep, B, high-grade sleep, sleeping more than 50% with neurological symptoms, progressive pain, and mechanical deterioration of deformity. With type 2, adults with low-grade spondylolisthesis, failure of non-operative treatment, this is an indication for surgery. Type 2B, adults with high-grade spondylolisthesis with symptomatic patients with low back pain and radiculopathy and in high-grade slippage. Type 3, A and B are adults older than 40 years with low-grade spondylolisthesis and degenerative spondylolisthesis. This is treated with the general pattern of degenerative spondylolisthesis, persistent pain, neurological pain, claudication, failure of conservative treatment with progressive neurology or bladder or bowel symptoms. These are the criteria of surgery. We, again, it is the children and adolescents with low and high grade slippage, adults with low and high grade slippage, and the adults more than 40 years with advanced degenerative listhesis or adjunct degenerative spine. Treatment should be, decision-making should be individualized for each patient. We think for the slippage, we think for the severity and duration of symptoms and comorbidity. Surgical indications, as we see, is the severe back and leg pain and failure of conservative treatment. Surgical goals deal with the pars defect, decompress the foramina, deal with the degenerative discs, and deal with the dynamic instability. The surgical options was in situ posterolateral fusion, decompression, and in situ posterolateral fusion. We add the interbody fusion, circumferential fusion, reduction and fusion in the severe types, anterior corpectomy, and posterior reduction and fusion. We should look for the level above, as with the grades of high grades of spondylolisthesis, L5S1, there will be retrolisthesis of the level above. With the interbody fusion, it is also, it will add to the stability and decrease the pseudoarthrosis. Types of interbody fusion is the PLIF, the posterior lumbar interbody fusion, transforaminal lumbar interbody fusion, and anterolateral interbody fusion. هنشوف بعض الحالات. هنا في عندي 50% or grade 1 داخله على 2, slippage, unstable with extension and deflection, in MRI, the case above is that somewhat good. And as we see here, it is with stenosis. The technique, we screw the sacrum, the L4, and then we screw the L5. If we have the reduction screw, it will be good. If not, we use the trial of the cage of the PLIF or T-LIF to distract the vertebra, and then we will apply the rod, apply the distraction, and we reduce and tighten the L5, as we see here, reduced with a cage in between for anterior interbody fusion. Posterolateral, this is circumferential fusion, posterolateral and interbody fusion. This is with weight bearing. It is now balanced, as we see here, both in the lateral view and in the anterior view, with the posterolateral fusion bulk here appears well. Case 2, it is a severe case with a female aged 19 years with low back pain, neurogenic claudication since 2 years, standard lower lumbar region with a hump. Lumbar flexion is limited to the mid-thigh. Here is, as we see here, there is a flexion of the hip and flexion of the knee with a hump, lumbosacral kyphosis. As we see here, this is grade 5 spondylolisthesis, dysplastic type with rounding and verticalization of the pelvis, as we here see in the MRI also. Treatment, conserve, surgical treatment, decompression, in situ fusion, all the modalities of treatment. Here, with such grades, Gaines procedure for anterior complete corpectomy and L4 S1 fusion. We have modified this technique by partial excision or partial corpectomy, anterior corpectomy of L5, decortication of the sacral plateau and posterior fusion in another session. This is after the first session with partial corpectomy of L5. Here with fixation, posterior fixation, L3, 4, S1. We use the remnants of L5 as a graft for anterior fusion. This is the post-operative, and this is late. This case was done in 2005. Here is the remnants of L5 as we see, and 3, 4, S1 fusion with a balanced spine. And we use this somewhat still vertical to add for the compression over the remnants of L5 as a graft to heal. The recommendations: choose the surgical targets carefully, assess the pelvic parameters, restore the sagittal balance. 30 degrees, 30-60, 360, or the circumferential fusion is recommended. No reduction techniques allows reduction for a lot of cases. New reduction techniques allow reduction for a lot of cases, and ensure the patient expectations that will match your goals. Thank you. معلش أنا طولت عليكم جدا.
لا العفو يا فندم، العفو. Interesting talk دكتور أشرف بيه.
ربنا يخليك. شكرا.
Thank you so much. دكتور جلال باشا.
شكرا يا أستاذ الدكتور أشرف إسماعيل for this very enlightening lecture. Here you have mentioned very important points regarding the geometry of the spine, the balance of